What is up, everyone? Welcome back to the channel. It is my second to last week of my internal medicine rotation. This week I'm on Team B, which is one of the resident-based teams. It's honestly been a while since I've been on one of these teams. Last time was, I think, my second week of the rotation, so it's been like over a month. This past weekend was really nice. Today is Mackenzie's birthday, actually, so we celebrated on Saturday. We went out to dinner, which has been a while since we've done that. Very easy to get caught up in rotation studying because we're a lot more busy than we were even in preclinical. So I'm really glad we were able to take a little bit of time off and just relax. It's honestly not great weather here up in New Jersey. We've had some snow recently, which is the first snow of the season, and it really didn't snow much last year, so pretty difficult to get used to having to leave a little bit earlier to make sure my car defrosted and all that. Thankfully, I don't have a long drive to the hospital. It's only like 5 minutes, so I really don't have to worry about driving in the snow that much, but I know some of my classmates still live pretty far away, like 40-45 minutes, so for them it's been pretty rough. But yeah, so like I said, I'm back on one of the resident-based internal medicine teams. A little bit different than the one that I was on my second week. That one was pretty huge, but this one, the ICU has needed a lot more help, so they've pulled some of the residents from this team to work in the ICU. So only actually one resident on the team, and then it's gonna be me and one of my classmates and then an attending. So it's gonna be pretty small, but it's honestly good because I'll be able to get a little bit more like one-on-one instruction from everyone. Alright, so it is Wednesday. I just got done with the gym, and all in all, I've been liking this week a lot. It's honestly pretty different from the last time I was on like a resident-based team, which was actually like week 2 of my rotation. So my first week, we were really just like hanging out with the interns because it was our admission team week, so we were just kind of responding to rapids and doing admissions. And then my second week was like the actual resident-based team week, where basically how that team was set up was there was 2 seniors, an attending, 5 interns, which I think is a lot, and then 3 med students. So it was a huge team. We were carrying a list of like 25 to 30 the whole week. It was only our second week, so I was only seeing like 2 to 3 patients a day. And compared to this week, I had a lot less responsibility. Part of it is probably because we had interns that week, a lot of interns, so they do a lot of the, not grunt work, but they're just a lot busier than med students, and especially a lot busier than I was since it was my second week of rotations ever. But that week, aside from, you know, going and seeing my patients, reading up on them, I didn't do a lot. Like anytime we had to call family or go back, talk to nurses, check up on them in the afternoon, usually it was the interns that were doing that. But in contrast, I've been doing that this week. Part of it is because there are no interns on the team. This team is a lot smaller. It's just 1 attending, a PGY2, and then 2 students. Very different. We only have like 6 or 7 patients, so still about like, you know, 3 to 4 patients each, but the team itself is just a lot smaller. But because of that, I've been able to spend a lot more one-on-one time with the PGY2. It's a little bit more personal when we're rounding with the attending, and I just get to do more in terms of, like I said, going back in the afternoon to check up on the patient. If any labs come back abnormal, you know, talking to the nurses about what we need to change, calling family is, you know, this is the first week that I've actually had to call family and like update them on what's going on or ask for more information. So yeah, it's been really good having some added responsibility. I still can't really do that much as a student. Even my PGY2 said that. He was like, you know, you guys are great, but I wish you were interns. I wish you guys could put in orders and stuff, but unfortunately that's just not where we're at right now. The other cool thing with this team is it tends to be some of the more complicated patients in the hospital. You know, we have already had a few sort of transfers from other teams or just like solo hospitalists to our team just because we need more eyes on the patient. And because of that, I've just been learning more. I mean, we've had patients with stuff that I thought I would only see in UWorld, so it's really nice to see that stuff in person because things are going to stick a lot better when I do have those kind of questions on my exams. I had 2 patients this week where the attending's like, oh wow, like this would be a really good case to write up because it's just something that doesn't happen that often. I've honestly been staying at the hospital for longer than I have on other teams. Once again, I think that is just because the team is smaller, there's no interns. We need to stay longer to do stuff. Like one day we had an admission that was called at like 3 o'clock, and those take a while. So between chart reviewing the patient, going and seeing them, researching stuff, talking to the attending, it took like another 2.5 hours, and it didn't leave until 5:30. So I guess that is the one downside, but we do still have a lot of time during the day to get studying done, so I really still haven't had to come home and do anything. Only got 2 more days of this, which is crazy. It's kind of flown by, but it's been good. All right, that is it for right now. I will check in later. Alright, so it is now Saturday. I have a few updates on the week. So Thursday was a bit of a shorter day in the hospital because we actually had to go all the way up to campus for our lectures. In all of our clerkships, we usually have one day that's dedicated to lectures, or what they call core curriculum. For some rotations, you have the day completely off, like I think family medicine and surgery. Like I think every Monday you just don't go into the hospital, you're just doing lectures all day. For IM, it's a little bit different. They try to make Thursdays the core curriculum day, but it's usually just having lectures in the afternoon, so you still have to go in the morning, round on your patients, and then you'll leave a little bit early to be able to make the lectures. Sometimes it doesn't always work out like that. We'll have a random lecture on a Tuesday or Wednesday, but for the most part, it's been Thursdays. And usually they're virtual, which is really nice, especially for the people who are stationed in the South, because driving back up to campus can take like an hour, hour and a half. But unfortunately, for whatever reason, this week's core curriculum was in person, so I had to leave the hospital around 12 to make it up to campus. We had a few really good sessions though. The first one was on altered mental status. It was given by one of the geriatric medicine physicians up at our main hospital, and the reason is altered mental status is a more common issue with the elderly. So that was about an hour, and then we had a 2-hour discussion about ethics actually. So earlier in the week we were asked to think of some sort of ethical dilemma that we've seen on our rotations and send in sort of a description of it. Our professor compiled all of them and picked a few for us to sort of do an in-depth analysis and discussion of them. I honestly didn't really have anything to say, but some of my other classmates had some really interesting and common issues come up. Like one of the more common things that you think of in terms of like ethical issue in medicine is someone comes in, they're anemic or they're bleeding profusely and they need to be transfused some blood, and it is against their religion. So talking about how to navigate through that. There was another one about, a patient has this sort of very serious terminal diagnosis that explains all of their symptoms, but the family doesn't really want you to share it with them for whatever reason. In this patient's case, it's because the family thought that she would become too anxious and worked up with knowing that diagnosis, that it would just do more harm than good. So that was probably the most interesting discussion because, you have to consider that, especially in the case that the patient has full capacity, it's not like they have an official healthcare proxy. The family can't really make any decisions. It's really up to the patient. At the end of the day, we are patient's doctors, not the family's doctor. So we have to act in a way that is always doing the most good for the patient. So at least for this situation, one of the good compromises that we came to was simply just asking the patient, like, hey, we did some tests these past few days. We have the results. What do you want to know about them? Do you want to know sort of the bare minimum? Do you want to know nothing at all and we'll just go through your family for everything? That way the patient is still able to make that decision for themselves, but you're also not really disrespecting the family because the family knows the patient a lot better than you do. So that was it in terms of lectures. Friday morning, we actually had to give morning report. So I'm sure works differently at every hospital around the country, but morning report is typically like a morning lecture where, at least at our hospital, one of the resident teams will present one of their interesting patients and sort of, you go through, they say the HPI, review systems, physical exam, then sort of open it up to the audience. Hey, what differentials are in your guys' minds? What stuff do you want to order? Then they'll go through the labs and imaging and eventually get to a certain diagnosis. Then at the end, what the students typically do is teaching points, essentially. So based on whatever issue the patient had, they will, go over some sort of criteria or how to treat it, how to diagnose it, that kind of stuff. I'd done that once before. It was during my second week. This week it was a little bit different because it was literally just one resident and then me and another student. So we couldn't really do the whole, the resident gives the whole presentation and then the students focus on the teaching points at the end. We all just kind of split everything up. So everyone was presenting part of the actual case. We did the presentation on one of my patients, actually. So for a very quick synopsis, basically the patient came in with a hypertensive emergency, which is defined as a patient having a blood pressure over 180 with some sign of organ damage. If the patient didn't have any organ damage, then it would be categorized as hypertensive urgency. We determined that it was probably an emergency because of some of the patient's labs, but anyway, the patient comes in very, very hypertensive, up to the 240s. The patient is already on 5 antihypertensives at home and doesn't really have a good control over their blood pressure. So we do a lot of initial tests, including stuff for causes of secondary hypertension. So primary or essential hypertension is the much more common cause of hypertension, where it's due to things like lifestyle, genetics, lipid levels, that sort of stuff. Secondary hypertension is hypertension caused by a different medical issue. So something like a pheochromocytoma or renal artery stenosis. So because the patient had this long history of hypertension with all of these different medications, we're like, all right, let's try to look for a different cause of this hypertension. A lot of the initial workup from like the algorithms on UpToDate were negative. Didn't have a pheochromocytoma, no renal artery stenosis, no hyperthyroidism, nothing like that. So I think one of the cardiologists actually wanted to get a cardiac MRI for some reason. We didn't really know why, but eventually it made sense. But after looking at the MRI, there was this like infiltrative cardiomyopathy, which the radiologist thought might be amyloidosis. Amyloidosis is pretty complex and there's a few different kinds, but basically you have these proteins that deposit into your tissues. So it can deposit into your skin, your lungs, your heart, your kidneys. So once we got those results, we were like, oh yeah, this could explain the patient's hypertension. If the amyloid was depositing into the right part of the kidneys, it could definitely cause resistant hypertension. The patient actually just ended up needing dialysis because of how much damage had been done to their kidneys, but thankfully they're doing a lot better. They're going to go home next week, so that is all good. Pretty interesting that I saw something so rare this week, and that was my patient. But yeah, thankfully the presentation went pretty well. Pretty crazy that I only have one more week of internal medicine, and it's a short week. We have Monday, Tuesday, Wednesday of actual like clinical responsibilities, then Thursday we have our OSCE, and Friday we have our shelf. Some students are already done with their first clerkship. The way that my school sets it up, there's either 8-week or 6-week clerkships. So if you started on your 6-week ones, you're already done and you're on your second clerkship. And a week from now, I will be prepping for my surgery rotation. And honestly, I enjoyed internal medicine a lot more than I thought I would. Maybe it's just the novelty of actually doing rotations, but I think it was really nice to use a lot of the knowledge that we learned in preclinical pretty much every single day. It is going to be interesting to see how surgery differs from internal medicine. Obviously, the whole actual surgery part is very different, but I just mean in terms of using the knowledge that I learned in preclinical on like a day-to-day basis. All right, well, that is going to do it for today's video. If you enjoyed, please be sure to leave a like below and subscribe if you want to see videos like this in the future. Thanks, and I'll see you in the next one.